Frank, John, and I appreciate the opportunity to provide you with an update of the activities of the COA and the revisions to the AACN Essentials. But before we get started, please allow me to take a moment to acknowledge the important work of the COA board and staff. They have done a tremendous job, especially this year, given all of the challenges of the pandemic. So a special thank you to them. And I'd also like to recognize those who serve as on-site reviewers and consultants, because the COA could not complete its accreditation activities if it was not for these dedicated volunteers. They put forth an exceptional effort for our organization every day and deserve special recognition. We have no conflicts of interest to disclose. And here are the key topics that we're going to discuss today. First, we're going to go over the accomplishments of the COA for 2020, and then review the activities that we have planned in 2021. We're going to review the 2020 annual report data, and we're going to also talk about the approved revisions to the accreditation policies and procedures and standards. And finally, we'll discuss the revisions to the AACN Essentials. So starting with the program status, there are currently 124 accredited nurse anesthesia programs, and there are 2,086 active clinical sites. We have 7 new programs in capability. These are the University of Evansville in Evansville, Indiana, Northwestern State University in Natchitoches, Louisiana, South College School of Nursing in Knoxville, Tennessee, the University of Mobile Nurse Anesthesia Program in Mobile, Alabama, Hofstra Northwell Graduate Program in Hampstead, New York, and LaRoche University in Pittsburgh, Pennsylvania. Regarding the policies and procedures, a total of 34 revisions to the accreditation policies and procedures were revised by the COA in 2020. Many are related to changes in USDE recognition requirements. The policies and a summary of the revisions are noted in the addendum of the program director's updates. There was also 3 calls for comments on the proposed revisions to the accreditation policies, procedures, and standards. Regarding special interest groups, the Council has 2 special interest groups. The first is the Common Clinical Assessment Tool Special Interest Group, and the second is the Diversity, Equity, and Inclusion Special Interest Group. The CCAT was set to be piloted in 2020, but because of all of the issues related to COVID, those activities were postponed, and we're hoping that we can resume those sometime this spring. In October, the COA approved the establishment of the Diversity, Equity, and Inclusion Special Interest Group. The focus of this special interest group will be on accreditation-related activities, and this group will start its work sometime this year. For technology, the development and testing of new accreditation software platform was completed, and also the COA launched a new website in January 2020. So regarding the key activities planned in 2021, these are the projects that the COA and its staff are working on. First, the co-access replacement project. The new co-access software will be implemented this summer. As you all know, we've had a lot of activities related to COVID. These included sending surveys to programs to identify the impact of COVID, and the COA issued revisions and clarifications on accreditation requirements. Transitioning programs to the doctoral degree. The COA will continue to support programs transitioning to award doctoral degrees, and Frank will be providing an update on the current status. CHIA and USDE reviews. The COA is currently being reviewed by CHIA for continued recognition. And in addition, a petition to start the review process by the USDE is scheduled for submission in July. Regarding distribution of the revised standards, the COA will be reviewing revised standards as part of this presentation, and this was also noted in the February Program Director's Update. A summary of the revisions is also posted on the COA website. This year, the COA conducted an accreditation business assessment to increase efficiencies and self-sufficiency. And then finally, one additional activity that's not listed here, but will affect nurse anesthesia programs, is the revision of the AACN Doctoral Essentials. And this will be discussed later in this presentation by Dr. McFadden. So now I'll turn it over to Dr. Frank Gervasi to report on the 2020 annual report data.
Thank you, Laura. I'd like to take this opportunity to highlight some of the trends that we see in nurse anesthesia education I'd like to start by saying a special thank you to all the programs that completed their 2020 annual reports. And also to note that a summary is posted on the members only side of the AANA website. I'd like to start by showing this figure, which shows the number of programs awarding master's degrees. That's in the light blue, doctoral, which is in the black, and then the total, which is in the purple shading in the calendar's years 2009 through 2020. It's interesting to note that 14 new programs were established between 2009 and 2020. The figure shows that we've had an increase in the number of programs awarding doctoral degrees and a steady decrease in those programs awarding master's degrees for entry into practice since the AANA released its position statement and since the COA established a deadline for programs to transition to award doctoral degrees. Currently, we have 103 or 83% of the programs that have been approved to award a doctoral degree for entry into practice. As far as programs continuing to transition, the deadline date is January 1, 2022. Currently, we have a total of 103 programs that have been approved to award an entry-level doctoral degree and 25 programs that are awarding postmasters doctoral degrees for completion for CRNAs. So the remaining 21 programs have approximately 1 year in which to transition to award a doctoral degree for entry into practice. This slide just shows you the number of CRNA faculty with doctoral degrees. And I'm pleased to report that you can see from this slide, the number of faculty have continued to increase over the years. In 2018, we had 1,059 CRNA faculty with doctoral degrees. In 2019, it was 1,164. And in 2020, we have 1,333. So we've continued to see a steady increase in our CRNA faculty with doctoral degrees. Now, the next slide is going to look at our percentage of students that left the program for a variety of reasons. And this is for attrition rates. And you can see overall, the attrition rate for nurse anesthesia programs is relatively low, and it stayed at approximately 6% plus or minus 8%. I would like to note that the COA does follow up on programs whose attrition rate is over 10%. Now, I would like to discuss some of the approved revisions to the accreditation policies and procedures that have occurred over the past year. In regard to changes to accreditation policies and procedures, at its June 2020 meeting, the COA made several changes to policies and procedures, and these were related to new U.S. Department of Education requirements. These changes went into effect July 1st of 2020. The changes included a change in the disclosure process for adverse decisions in regard to the deadline for compliance with standards and criteria related to the certification exam, and also deadlines for compliance with the standards overall. The main change was in a change in the time frame that programs have to come into compliance with the standards. And that was changed for a maximum of 2 years to an increase to 3 years to come into compliance. And that impacted these policies and procedures. If we look at the next slide, you'll see additional policies and procedures that were implicated. These included the certification exam, probation, revocation, and program closure and teach out policies. The main changes here also related to some of the information that has to be shared with programs and shared with students and potential applicants. And that included programs when they're placed on probation, as well as programs that have been placed on revocation. The programs are required to inform their currently enrolled students of those actions. And as far as teach out and program closures, the change there related to a requirement that students be informed if if the program has been placed on either probation or revocation, and there's new requirements related to the information that programs have to submit. So moving forward, I would like to turn this back over to Laura to discuss some of the revisions that were approved in the accreditation standards.
In addition to the revisions to the accreditation policies and procedures, the COA at its January 2021 meeting approved significant revisions to its practice doctorate standards and guidelines for counting clinical experiences. These revisions were made in response to recommendations from the Full Scope of Practice Competency Task Force, the COA Standards Revisions Subcommittee, and the COA Standards and Policies Committee. So we'll begin with discussing some of these revisions. In order to gather feedback on the Full Scope of Practice Competency Task Force recommendations, the COA conducted 3 calls for comment in May, August, and November 2020. In total, the COA received 584 completed surveys from members of its community of interest, which included 292 CRNA practitioners and 188 CRNA educators. Nearly 75 student registered nurse anesthetists also provided their comments on the proposed revisions. The revisions to the doctoral standards, accreditation policies and procedures manual, and guidelines for counting clinical experiences will be effective for all students matriculating into accredited nurse anesthesia programs on or after January 1st, 2022. So the first change is the addition of a glossary definition of competency. So the approved change was to add this definition, which reads as follows. Competency is an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes. Since competencies are observable, they can be measured and assessed to ensure their acquisition. Some of the key points here is that we did not have a glossary definition of competency, and this definition here is a well-supported definition. The source of the definition is Englander et al. 2013, which was the same source used for the Common Clinical Assessment Tool. The AACN's revision of the essentials could have an impact, but it's still in progress and not yet available. So here we will also be adding a glossary definition of competence. And it reads as follows. The array of abilities, knowledge, skills, and attitudes, or KSAs, across multiple domains or aspects of performance in a certain context. Statements about competence require descriptive qualifiers to define the relevant abilities, context, and stage of training. Competence is multidimensional and dynamic, and it changes with time, experience, and setting. And so again, the key points here is we did not have a definition in our glossary, and this aligns with that same source, Englander, which is a well supported generic definition. So next change is in regards to total case number requirements. The approved change was to add this requirement to the appendix, clinical experiences of the doctoral standards. And this is to increase the minimum total case number to 650. So this would, again, impact all students matriculating on or after January 1st, 2022. So the key points here is that this is supported by benchmarking against requirements of other anesthesia provider accreditors. And in looking at the NBCRNA data from 2018, it should have minimal impact on programs and students. The impact of the increase on types of cases students obtain will be examined by the COA once all programs are at the doctoral level and have graduated students, and we can obtain sufficient transcript data. The next change is to establish a minimum number of cases for ultrasound-guided regional and vascular access. And that's to establish a minimum requirement of 10 ultrasound-guided regional and 10 ultrasound-guided vascular access placements, rather than only having a preferred number. So for ultrasound-guided techniques, regional and vascular, under each, we will add lines to track actual and simulated. And we would allow the use of simulation to meet this requirement. The key points here is that making this a requirement versus preferred will help ensure that CRNA programs stay on the forefront of anesthesia practice. According again to the latest NBCRNA data, it appears that the numbers of regional anesthesia cases are increasing, and this may be in part due to simulation. The types of vascular access not specified as central, peripheral, or arterial should be easy to obtain. Also important to note is that the minimum case numbers here are higher than those that were proposed by the full scope of practice competency task force. Qualified faculty to teach ultrasound guidance may be problematic for some programs, but probably will not remain an issue over time due to the increased number of CRNAs with ultrasound training. And here you can see how this will appear. And again, the notation here regarding regional anesthesia is that regional includes neuraxial, truncal, or peripheral nerve blocks, and that no clinical experiences can be attained by simulation alone. Vascular includes arterial, peripherally inserted central catheters, central venous, and peripheral access. And again, no clinical experiences can be obtained by simulation alone for either. So additional changes related to point of care ultrasound is that we would add the following definition, a glossary definition to the doctoral standards. That point of care ultrasound, or POCUS, refers to the use of portable ultrasonography at a patient's bedside for diagnostic, e.g. symptom or sign-based examination purposes. And this is exclusive of using ultrasound for image guiding purposes, such as for regional anesthesia or vascular access. We would add the following in the appendix are the clinical experiences of the doctoral standards, is to add POCUS with no case number requirement, but we would require students to track this. The key points here are that there has been a rapid escalation in the use of POCUS for assessment and diagnosis, as well as vascular and regional access. Currently, POCUS does not appear in the standards for curriculum. So this proposed standard addresses the use of ultrasound for more than just vascular access and regional guidance. And here you can see how this will be reflected in the standards appendix. You will not have a preferred or a minimum number, but you would be tracking that. Next is the addition of a glossary definition for full scope of practice. And that definition reads, preparation of graduates who can administer anesthesia and anesthesia-related care in 5 general categories. 1, pre-anesthetic, pre-procedure. 2, intraoperative, intra-procedure. 3, post-operative, post-procedure. 4, pain management. And 5, other services. These are general categories. And we note that scope of practice is dynamic and evolving. The key points here is that there was a disconnect between the generic one-sentence definition proposed by the full scope of practice competency task force and the AANA definition, which addresses categories of care. Next is to revise the radiology definition and to establish a clinical experiences requirement to support the didactic content for chest X-ray interpretation. So the definition changes here are highlighted in yellow, that we would add proper techniques of safe fluoroscopic equipment use, evaluation of normal and abnormal radiographs of the chest where findings may have peri-anesthetic considerations, evaluation of proper positioning of various devices such as endotracheal tubes or chest tubes, and invasive vascular access catheters such as central venous catheters. And experiences in chest X-ray interpretation are offered. And this proposed definition incorporates the recommendation to add clinical experiences that support the didactic content. So we know while programs have radiology and chest X-ray interpretation didactic content, programs vary on providing experiences in actually interpreting chest X-rays and do not universally provide this experience. So the next change would be establishing a minimum and preferred requirement for interpretation of chest X-rays to support the didactic content. And what we would add would be that the expectation is that the student accurately recognizes normal and abnormal findings on chest X-rays that may have immediate peri-anesthetic implications, such as a pneumothorax or pulmonary edema, along with evaluating proper positioning of various tubes, endotracheal tubes or chest tubes, and invasive vascular access lines like central venous catheters. So the proposed definition incorporates the recommendation to add clinical experiences that support the didactic content. And programs indicated that a formal radiology rotation is not an option, and simulation has effectively bridged the gap between the classroom and the clinical setting. Radiology operates on a mostly virtual platform, meaning that the clinicians can read the image in remote locations to the patient. So, one case should be counted as the evaluation of one chest x ray, and student's evaluation is assessed. The chest x ray source can be a current or past patient, or from an institutional or commercial library of chest x rays. And this experience can be gained in the healthcare institution, classroom, simulation, or by using online resources. So here the assessment of chest x-rays, the minimum required would be 5, the preferred number would be 10. In regard to evaluation of the student's interpretation, the evaluator should be an appropriately credentialed provider. So the next change is to add 12 lead ECG interpretation to the curriculum, and this would fall under the doctoral standards E2.2. And you can see it here under where we include all of the curriculum aspects. That 12 lead EKG interpretation is going to be added here. And the key points is that safe care can be contingent on the CRNA being able to interpret a 12 lead ECG to detect such conditions as myocardial ischemia and infarction in emergency situations, and when the patient is being monitored using properly placed ECG electrodes. So we would also be adding the 12 lead EKG interpretation glossary definition, which means didactic curricular content in the use of 12 lead ECG to detect cardiac abnormalities having peri-anesthesia implications. Next would be to add examples to the comprehensive history and physical assessment definition. And you can see here highlighted in yellow what we would add would be that regarding comprehensive history and physical assessment, the examples including but not limited to laboratory, radiologic, and other diagnostic studies, e.g. chest x-ray, 12 lead ECG, and point of care ultrasound as appropriate. And the key points here is expanding the definition of comprehensive history and physical assessment with specific examples emphasizes the importance of these skills and techniques to independent CRNA practice. And the proposed changes are aligned with the AANA scope of practice documents, order, evaluate, and interpret diagnostic, laboratory, and radiologic studies. And this is just continued from the previous slide. The results of a comprehensive history and physical assessment are used to establish a differential diagnosis based on assessment data and develop an effective and appropriate plan of care for a patient. Specific assessment related to anesthesia should be stressed in the practical experience of nurse anesthesia students. Now I'm going to turn it back over to Frank to complete the rest of the revisions.
Thank you, Laura. This slide looks at the approved experiences that focus on pre-anesthetic assessment, post-anesthetic assessment and management, and a comprehensive history and physical assessment. In regard to patient assessment, which is a new category, the minimum required number of cases is 50, and the preferred number is 100. The approved guidelines change accounts for the pre-anesthetic assessment and identifies what is included in a pre-anesthetic assessment. An important point to consider is that the pre-anesthetic assessment is part of the AANA scope of practice. The pre-anesthetic assessment is fundamental for the independent practitioner. And by adding this category in the clinical experiences log, this will allow the COA to track data for compliance and make further future adjustments to requirements if necessary. The next change, which is also a new category, is the addition of the post-anesthetic assessment. The minimum required cases would be 50, and the preferred number of cases is 150. The approved guidelines now identify what is entailed in a post-anesthetic assessment and the information that the student should be assessing when conducting a post-anesthetic assessment. It is noted that due to many factors beyond the control of the student, each patient that the student anesthetizes is not required to have a post-anesthetic assessment performed by the student. And the program must have a process for validating post-anesthetic assessments if they're not documented in the patient's medical record. It's important to note that post-anesthetic assessments are part of the AANA scope of practice, and that a post-anesthetic assessment is fundamental to independent practice. And also, by having this in our clinical experiences log, this will allow the COA to track data related to post-anesthetic assessments and compliance and make future adjustments if necessary. The next new category added was a comprehensive history and physical. There is not a minimum required case number or preferred case number for this new category. In the guidelines, there is a change, and the comprehensive history and physical assessment is identified in the guidelines and what should be included in a comprehensive history and physical assessment. It's very important to note for this new requirement that this is not a pre-anesthetic assessment. This assessment is a complete history, physical, psychological assessment of the patient. It will include assessment of all body functions using inspection, palpation, percussion, costillation, and advanced assessment techniques. It's a complete physical assessment. And it is important to note that for this, this is an important criteria for CMS regulations for CRNAs to complete history and physicals. And it's important that the council and programs be able to demonstrate that this is part of the curriculum. It should be noted that simulation for the comprehensive history and physical should be an effective option for this experience. The next requirement is under methods of anesthesia, and the requirement is to perform a general anesthetic induction with minimal or no assistance. The minimum required number of cases is 50, and the preferred number of cases for this category is 100. And the approved guideline change for this defines what is required for a student to meet this requirement of conducting a general anesthetic induction with minimal or no assistance. It identifies the various aspects of induction, including standardized monitoring, pre-oxygenating, selecting and administering the induction medication, and managing the airway and ventilation with minimal or no assistance from the supervising CRNA or physician anesthesiologist. This is an important requirement because students may graduate never having done an induction without the supervision of a provider, and may not have had the opportunity to select and administer the medications. This requirement will address that. The guideline statement assures that the supervisor approves the plan of care. Now, it's my pleasure to introduce Dr. John McFadden, who will discuss the re-envisioning of the AACN Essentials.
Thank you, Frank. It's been an honor for me to serve on the AACN Essentials Revision Task Force as one of its 3 co-chairs. My experiences as a CRNA, CRNA educator and program director, and COA chair reviewer have served me well during this endeavor. I was able to help the others on the task force understand our unique curricula and requirements. It's not lost on me that we have very specific skills that we must ensure our graduates leave our programs possessing. It's what makes our graduates so different than other advanced practice providers. The current essentials have served us well for well over a decade. So why the need for a change? Well, if you haven't looked closely at your iPhone recently, maybe this is a good time to do so and remind ourselves just how fast our world is changing. Just from my little phone, I can set the temperature in my house, heat my swimming pool, make travel arrangements, and pay my bills. Many of these technologies didn't exist a decade ago. Disruptive innovations are no longer just breakthrough technologies. They're rocking the world of nursing and anesthesia education as we know it. We're all using platforms and techniques we would never have considered even just 12 months ago. In fact, we frequently would say the technology and approaches we're now using could never work, but they are. So re-envisioning the essentials is timely, it's relevant, and it is certainly necessary. Let me provide you with some background information about our journey so we're all on the same page. If you've attended any of the AACN meetings about the new essentials, some of this may look familiar already. There are 3 of us who chair the task force. My partners are Dr. Jean Giddens and Dr. Cynthia McCurran. We're joined by 3 experts in higher education, Dr. Nancy DeBazio, Dr. Linda Caldwell, and Dr. Jean Bartels serve as our consultants. My esteemed colleague, Dr. Lynn Zahn, serves as our board liaison. And of course, we have an amazing AACN staff who shepherds us. Our task force members represent a cross-section of educators and practice partners with varying degrees and experiences in nursing who provide a wealth of perspectives and ideas. Our practice partners were incredibly informative to us. They helped us understand the challenges they're having with the end product of our educational programs, that is, our graduates. We learned that our practice partners continue to struggle with high turnover of new nurses. And that impacts us as nurse anesthetists because we draw our students from our BSN programs and practicing critical care nurses. Another issue we heard about is the need to focus on self-care to prevent burnout and addiction. And AANA and COA certainly have been leaders in promoting wellness and self-care in our profession. One of our practice partners told us she's observed inconsistency among graduates across all degree levels and variability in length and expectations of programs. She came right out and told us, we're not sure what your product is. In addition, if there's a difference between the associate's degree nurse and the bachelor's prepared nurse, or the MSN and the DNP prepared APRN, this needs to be evident. She also expressed concern about the quality of our programs and the variability in their products. These comments really resonated with me because during my time on the AANA board and as a CRNA educator, I've heard similar comments from our clinicians and chief CRNAs. In the conversations within the task force, we recognized the chaos that exists within nursing education. Many of our nurse colleagues in practice cannot articulate what nursing is. They can't differentiate between levels of practice or even explain our educational pathways. While I believe the overwhelming majority of CRNAs can explain our educational pathways, many are struggling to explain the difference between a master's and doctoral prepared nurse anesthetist. So we use this opportunity to re-examine many issues that plague our profession, from the need for interdisciplinarity to evidence-based practice and the call for nurses to be leaders at the bedside, in the operating room, in the boardroom, and when needed, in the legislature. As we progressed, we balanced using the same language as our other healthcare colleagues against emphasizing the uniqueness of nursing, lest we fail to identify what we uniquely bring to the patient. We also had to emphasize the biophysical sciences, physiology, pharmacology, microbiology, and other sciences, and still figure out how to work in the theories that are specific to nursing. So it has been a tough balancing act. And I've been quoted as saying it would be easier to get the members of Congress and the Senate to agree on an issue. So, high-level overview of the disruptive framework that we've embraced. We're using a modification of a framework first described by Englander and colleagues in 2013 as the discipline of medicine and allied health began working on competency-based education. So what we're doing is no different than our physician and other allied health colleagues are doing. The framework includes the use of domains, which are simply a category of like elements, in this case, competencies, that relate to each other. And this helped us explicate the competencies we were seeking to define and ensure they complement the other disciplines. One word of caution: the domains are not simply the titles of courses. That there are 10 domains does not mean that there has to be 10 non-anesthesia DNP courses in your curricula. Similarly, medicine did not come up with 10 courses for their curricula with these titles. Here are the 10 domains we propose. Although they match up with our other healthcare colleagues, we did give them a nursing bend. You'll notice throughout the document, there's a strong emphasis, particularly at the advanced level, on building the skills required for evidence-based practice. And just as in the last version of the essentials, it's recognized that we describe what is expected of graduates of all advanced practice specialties. And then our specialty groups, like the COA, will have specialty-focused competencies that are also required and complement our essentials. One of the early pieces of feedback we received from our members and stakeholders when they saw the 10 domains was that key concepts were missing. Well, they weren't missing, but they were placed within multiple domains. We had determined very intentionally that these concepts, as essential elements of our profession, couldn't be siloed into one domain. They go across many domains. So when you see the document, you will see that we crosswalk them to show how they're threaded throughout the document. So what is a competency? It's a pretty universal definition. It's an ability that is observable and integrates knowledge, technical skills, values, and attitudes. A competency is not a checklist, but we identified subcompetencies that, when combined, give an indication that a competency has been met. I like thinking of a competency as what a person can do with what they know. So think of competencies as the outcomes you want to observe, and then you determine the assessment technique, whether it's a case study, a presentation, a simulation, or in-person hands-on performance in clinical. You could even use a multiple choice test to measure some aspects of competence, but not all, just as you can't use a multiple choice test to assess a student's ability to competently perform intubation. So the competencies and subcompetencies aren't your assessment tools, nor are they a checklist, but you can use them to create assessments and map your curriculum. This is also a good time to note that competency-based education is a pedagogy. It was created by educators. It reinforces that seat time or hours simply do not equal competency. One question I've been asked: does that mean we could let some students graduate in 1 year and others graduate in 5 years? Well, higher ed in general is not yet ready to operationalize that, particularly for these types of professional programs. Maybe someday, but the research isn't there yet to let that happen. And this goes back to the age-old question that many of us have asked: how many intubations do you need to perform to be deemed competent? We all know in our gut it's not as few as 10. It's probably also not as many as 1,000. We also know performing 100 intubations in the controlled OR doesn't mean someone is competent to go out to a trauma scene on the heliport and be able to intubate. What we know is some learners do indeed achieve select competency outcomes quicker than others. Competencies mature over time and become more sophisticated and polished with ongoing practice. So repetition plays an important role in reinforcing competence. And it also allows us to throw in context nuances, like being able to intubate in the ICU or in the emergency room or even in the street. So hours and practice requirements are still going to be part of the learning process, even with competency-based education. And they're driven by our specialty organizations like the COA. This is an example of one proposed domain: quality and safety. You can see it has a description, and I know the font is somewhat small. It also shows competency 5.3 as an example. The sub-competencies that an entry-level nurse should be able to demonstrate is in the middle column, as well as those sub-competencies that a nurse who's engaging in advanced nursing practice education should be able to demonstrate, which is on the right column. This slide is a really good example of things that on face value look like they have little to do with CRNA practice, but upon rereading, you realize we do these every day and we just don't account for it, probably because it's second nature to us. Look at where the blue arrow is pointing. That's advanced subcompetency number 5.3E. Every day, we advocate for a culture of work environment safety. For example, we make sure the scavenger system for our waste gas is always working before we give an anesthetic. That's just one example of how our students, by the time they graduate, would advocate for initiatives that support a culture of work environment safety. And that's already assessed for because ensuring that our equipment is working is part of our daily clinical evaluation tool. This is a visual model of the disruption that our task force is proposing. We're not looking so much at degrees as we are the two levels. Regardless of whether you enter the nursing profession with a BSN or an entry-level MSN, you need to demonstrate the same competencies. Likewise, regardless of whether you graduate from an MSN program or a DNP program, you have to complete all of the requirements and demonstrate the competencies for advanced practice. Our specialty organizations, such as the nurse executives or the nurse geneticists or nurse practitioners or us as CRNAs, will also have competencies that have to be achieved. As I said previously, the essentials represent common competencies for all nurses that engage in advanced practice. And we, as CRNAs, for example, are in charge of our specialty-specific competencies. So let me try to relate this to CRNA education. There is very little new content in the essentials. It really is the essentials of nursing practice, ensuring that we can communicate with others, ensuring that we can engage in team-based care or interprofessionalism, making sure we can read research and apply it to practice, evidence-based practice, making sure our graduates can make ethical and legally sound decisions by the time they graduate, making sure we understand inclusivity, diversity, and we advocate for equity. I went through my program's curriculum and matched the content to the new essentials, and we already cover more than 90% of the content that's there. A colleague said to me, there's no time to assess all these new subcompetencies. I think you'll find you already are, and you don't realize it. Let me give you an example. I don't think any of us send our students into the operating room without making them simulate or demonstrate an induction and a machine check. One 30-minute induction simulation and debriefing sequence requires a student to demonstrate subcompetencies in communication, in critical thinking of their drug choices, in safety by doing their equipment checks, in ethics by checking informed consent, in team-based care by working with all the other providers in the OR, and in leadership by controlling the OR during induction. So you don't have to create separate tests or assessments for each competency or subcompetency. They can be measured concurrently. Not everything is going to be demonstrated in clinical. We know that. Some situations, like dealing with the impaired practitioner or confronting a hostile coworker, will be done in simulation or even using a case study in the classroom. There is a big focus on leadership skills, but don't mistakenly equate leadership skills with only the skills needed to be in the C-suite. CRNAs lead in everyday circumstances, and that's where the emphasis is in the new essentials. And I think sometimes we equate population health with community health. No one is expecting our acute care nurse practitioners or our CRNA students to be engaging in a community health rotation unless a faculty choose to include that experience in their curriculum. But population health is an inherent part of CRNA practice. We look at long-term health practices in groups, in populations, from smokers to those who are obese, to those with opioid addictions, and we address those needs in every anesthetic. We consider ethnicities and even discuss how populations with certain hair colors affect our anesthetic plan. That is part of contributing to and managing population health. We certainly teach our students to be prepared for disasters, from power failures during an anesthetic to the opioid epidemic to managing the COVID pandemic. So don't discount the vital role CRNAs play in population health and disaster preparedness. It's really imperative that our graduates leave our programs with these competencies. We had a lot of debate about how to highlight the nursing's unique contributions to care. Nursing drives the way we deliver an anesthetic. As I teach my students, we may all use the same psychomotor skills to place an epidural in a laboring patient. But the way I approach the 40-year-old prima gravida with an engaged spouse at her side is going to be very different than the way I approach the 15-year-old prima gravida who has no family support. We demonstrate intentional presence every time we echo the CRNA mantra that we will be vigilant and watching over our patients' every heartbeat and breath. Each time we enter the pre-op holding area and garner a patient's trust in less than 10 minutes, we show our expertise in engaging in therapeutic relationships and participatory care. And we coordinate the movement of patients from pre-op to intra-op to phase 1 and 2 recovery, sometimes directly to the ICU or the floor. That's our unique contribution to coordinating care across many settings. So I think you'll be surprised at how much we contribute to the wider healthcare system beyond the operating room. And we do it with such grace every day that we don't realize it. Last but not least, has anything changed with the DNP scholarly projects? The newly proposed revisions to the essentials recognize the importance of DNP graduates being able to manage a practice change based on the best available evidence. The recent COA white paper on the scholarly project served as a strong reference for the way the newly revised essentials approaches the project. I think you'll find close alignment. Innovation is encouraged and implementation, when possible, is desirable. Ultimately, it is recognized that faculty determine what is acceptable or not for a scholarly project, how dissemination is conducted, and how the project should be evaluated. So where does that leave us? Well, we've spent months incorporating feedback from many stakeholders, including our CRNAs and many program directors. The AACN board provided approval of our work, and we will be bringing it to the AACN membership, our academic deans, for a vote in March. The AACN website has many helpful resources for all of us to access. And in addition, we are creating a faculty toolkit, and AACN is constructing other helpful resources to help all of us better understand the document. We're planning programs for faculty to help them identify where many of these concepts are already in the curricula for CRNA programs, and help identify where there are gaps and how to address those gaps. Is it a little overwhelming? Maybe. But as I said when I chaired the AANA practice committee, the best way to eat an elephant is one bite at a time. And I hope this serves as one step forward for you, recognizing that this will take time for all of us to implement. Dr. Gerbasi and Dr. Roanano, I turn it back to you.
So thank you, John. Just a reminder, the revisions to the standards are posted on the COA website, and if you have any questions, please contact the COA. On behalf of the COA board and staff, we want to thank you all for your time today. We look forward to a great ADCE virtual meeting. And here you'll see pictured the COA board. Most unfortunately, we had to take pictures from our go-to meeting where we were all meeting virtually. We certainly miss taking our picture at the AANA office, and we certainly miss seeing each of you in person. So hopefully next year we'll all be together again. But again, we want to thank you for all of your time and look forward to having a great meeting.